Hey, hello. I'm going to go ahead and get started and introduce myself. My name is Abby Reese. I am a certified nurse midwife and the interim executive director of the New Mexico Perinatal Collaborative. And I've been asked to lead a session today that's focused on immediate postpartum long-acting reversible contraception. And I'm going to focus on breastfeeding and counseling considerations related to using LARC methods. So I am a nurse midwife. I want to let you know that my credentials for talking about breastfeeding and LARC are that I am a nurse midwife now 21 years. And I have worked with a contraception provider and have obviously worked with many, many women over the years around breastfeeding issues. I wish I could say that my initial training around breastfeeding was adequate back 21 years ago when I was in midwifery school. So I learned a lot of it through actually working with women and families. I think even a bigger learning experience for me, an important learning experience for me as a midwife, was having my own children. I have a 15-year-old daughter and an 11-year-old son, and the breastfeeding difficulties that I had with my 15-year-old after being a midwife in practice for 5 years at the time were extremely humbling and taught me a lot and taught me really to value the incredibly important work of folks who really focus on breastfeeding support. Certainly my mental health and my daughter's well-being were at stake. So I have that perspective, and it has informed my practice ever since. So I bring those things to my work around contraception. I want you to know that the New Mexico Perinatal Collaborative is a nonprofit organization that works to bring stakeholders together across communities and disciplines serving New Mexico families to improve outcomes for women, babies, and families. Breastfeeding is certainly incredibly important to the work that we want to do and the outcomes that we need to improve in our state. We're also really engaged around contraception because some of our initial work was through a grant that funded us to help hospitals in New Mexico to increase access to long-acting reversible contraception. So that's a little bit how we ended up in this space, and I'll talk about that more as I go through. You should know that I have no financial disclosures, and I will also spare anyone my rant about the commercial products that are involved in long-acting reversible contraception. That is definitely talk for another time. And here are the objectives I'd really like to try to cover. I want to make sure that anyone listening in could demonstrate knowledge of the contraception options available in the immediate postpartum, particularly the long-acting reversible contraceptive options. We're going to talk about risks and benefits of hormonal contraception in the immediate postpartum with a focus on breastfeeding implications. And then I'd like folks to be able to demonstrate knowledge of shared decision-making principles, which is spelled wrong. Sorry about that, as applied to comprehensive contraceptive counseling and breastfeeding support. So it's important to know that the immediate postpartum period, really that time right after someone is given birth, is a significant and often missed opportunity to address family planning goals. In the first year postpartum, when someone becomes pregnant, at least 70% of those pregnancies are known to be unintended. And we have routine guidance we give to women, or traditionally have given to women, leading up to a routine 6-week postpartum visit. Again, a subject for another day is really a critique of this whole notion of the 6-week postpartum visit, but that's still a very common feature of practice. And depending on the study, up to 3/4 of women acknowledge having unprotected intercourse before that visit. In fact, since I think we struggle to demonstrate the value of that particular time period, that 6-week moment, 10 to 40% of women, depending on the research, do not even attend. So if we really focus all our energy on identifying and implementing a family planning plan at that visit, we're often going to miss women when they are ready and need to take action. And that leads back to the first point about 70% of pregnancies in the first year postpartum being unintended. We also know that very often women who have decided that they would like to use an IUD postpartum don't obtain it. And then as far as women who are seeking postpartum sterilization for a variety of reasons, we know that at least a third of women who want to have that are not going to have that done. Anyone who works in the labor and delivery units knows that sometimes ORs are occupied. Folks who work with women breastfeeding postpartum in the hospital space know that a challenge that is often placed on women is the fact that we make them NPO and in anticipation of surgery on that first day when they're trying to rest, rehydrate, and stimulate a milk supply. So it's complicated, and there's a lot of other logistics involved. But basically, 47% of women who leave the hospital without having a desired postpartum sterilization will be pregnant within 1 year. There's a lot of problems with allowing these gaps to continue, but we also know that short interval pregnancies represent an independent risk factor for preterm birth and neonatal adverse outcomes, and it also is a specific challenge to breastfeeding. So this is something that we want to think about. What are the better opportunities to meet women where they're at? I just also want to make sure we're clear on what we're talking about when we say IPP-LARC or immediate postpartum long-acting reversible contraception. The photo on this slide shows really the 3 LARC methods. There are 2 types of IUD. The LNG, or the levonorgestrel intrauterine system, is the progesterone hormonal IUD. The copper T IUD is the alternative option in terms of IUDs. And then there's the contraceptive implant that can be placed in the arm, also a progesterone based method. First of all, we're not really focused on the copper T IUD because it has no hormones. There are absolutely no contraindications or even really theoretical concerns around breastfeeding. So we're going to leave that one to the side. Keep in mind, this could be an excellent option for someone who needs immediate postpartum contraception, wants immediate postpartum contraception, and also is very focused on their breastfeeding goals and objectives as well. But we'll leave that one to the side. Also, I want to say, when I'm talking about immediately, as far as the IUD is concerned, really basically what we're talking about is post-placental placement. So that can vary by institution, and there's no hard and fast rule. For the CDC, it's really, considered in terms of weeks or the first month. But we're really talking about after the placenta is expelled, 10 to 30 minutes before the woman maybe is moved into a postpartum unit, if that's the sort of institution it is, or really when the postpartum recovery begins. And of course, the implant, which is placed in the upper arm, can be placed at any point before hospital discharge. Part of the reason why our New Mexico Perinatal Collaborative immediate postpartum LARC project exists is because in 2013, New Mexico Medicaid created a policy that allowed these methods to be paid for in addition to the payment for the birth. And that really created an opportunity to provide what is really a very expensive service. Of course, there were challenges, and so we had a program to help hospitals get it up to speed. And while we were doing that, we learned that there were actually problems with the billing guidance as it was initially conceived. This is important because Medicaid covers about 72% of the births in our state, so a very significant percentage of women are going to have their births paid for through that program. Through our project, we learned what the billing barriers were for hospitals across the state, and we're able to take that guidance back to Medicaid and get revisions to the policy. So right now, the situation is that as of August of 2019, there is revised Medicaid billing guidance, which does make it possible for hospitals, regardless of what type of institution they are, to bill for LARC methods and the procedure, the insertion fee, in addition to the charges for birth. Unfortunately, this does not include EMSA, which sometimes covers births for women who are not otherwise eligible for Medicaid insurance. And commercial plans are not required to cover this yet, although it is something we are working on. And women should definitely be counseled to investigate with their private plans, if this is something they're interested in, and really ask for coverage for. But it's also possible that the answer will be it's included in the global fee, which is not going to be something that the hospital is going to agree with, and it could generate a separate charge for a woman. So again, that's a whole topic for another time, but we do have this revised guidance that makes it possible for Medicaid to pay, and we want to go back out and restart our training efforts and help hospitals implement this new policy. So this is something that you really should start hearing about, and hopefully statewide, which is why we all really need to think through what are all the concerns around offering hormonal LARC in the immediate postpartum period. So, I just wanted to also say that, LARC methods are very safe. There are very few medical contraindications to them, which is also really part of their appeal, and also part of the appeal for clinicians who provide these methods. ACOG endorses LARC as a safe and effective option for most women. And also, I didn't include a slide about this, but ACOG also endorses the provision of immediate postpartum LARC as an evidence-based practice to increase access to contraception and help women and people meet their family planning goals. But what about breastfeeding? A lot of folks who work with infants, with breastfeeding families, have concern about the evidence regarding the use of hormonal contraception in the early postpartum period when breastfeeding is just being established. And we know that this is a theoretical concern because of lactogenesis, and particularly lactogenesis 2, it really is triggered by this precipitous fall in progesterone right after the birth, and then also the fall in prolactin levels. But really, the question is, what happens when right after birth, when this abrupt physiologic withdrawal of progesterone happens when the placenta is expelled? What happens if we immediately reintroduce progesterone into that system? Here is, I'm going to present some of the recent evidence that we have trying to answer that question. The information on this slide comes from a systematic review that was published in September of 2016. The authors looked at 49 publications related to 47 studies that looked at indicators of breastfeeding performance, breastfeeding outcomes and initiation and duration, along with infant health. And they found that the range of studies, and this is a constant concern in the research, some of the studies were of poor methodologic quality, some of them were fair. Many of them have relatively low numbers, and also are really not able to be blinded in the traditional way of a randomized controlled trial, especially when a really explicit procedure needs to be involved in starting the method. So what this review found in terms of IUDs, again, keep in mind, we're looking at 47 studies here, but there was one new randomized controlled trial that found adverse effects on breastfeeding with immediate versus delayed hormonal IUD initiation. There was one new randomized controlled trial that did not. The rest of the studies found generally no negative impact on breastfeeding or infant outcomes. And for the implants, there was one new randomized controlled trial that found no adverse effects on breastfeeding with immediate versus delayed implant placement. And I should clarify that immediate is, before a discharge home. Delayed is probably around that magical 6-week postpartum visit time. That's or beyond. So for the implants, then the rest of the studies found generally no negative impact on breastfeeding or infant health outcomes as well. So this is also, this is updated, but is consistent with previous reviews and more more historical research going back a little bit further. I just wanted to highlight, kind of the dilemma when we're looking at the studies. These are the two IUD studies, two of the IUD studies with conflicting findings. Braniff published in 2015. I think this was evidence coming out of Australia. And you can see the numbers are small. In this randomized control trial, there were 25 women who received a hormonal IUD in the course of a cesarean, and then 19 women who received it at 6 weeks postpartum. They found at 6 months a higher proportion of breastfeeding in the immediate placement group versus the delayed group, significantly higher. But a trial that is raised specifically because it is the one that has identified concern is Chen from 2011, where 50 women with immediate postpartum placement versus 46 at 6 to 8 weeks postpartum. And there was a higher proportion of breastfeeding in the delayed placement group in that study versus the immediate group. At 6 months, there was a higher proportion also of exclusively breastfeeding in the delayed group versus immediate. But there were also no differences in initiation or the mean duration of breastfeeding overall. So this is what we're left with. There was also a Cochrane review published in 2015 that looked at more broadly at randomized controlled trials focused on hormonal contraception versus non-hormonal and or placebo. And the conclusion of the Cochrane review was that most trials did not find significant differences in breastfeeding duration, breast milk composition, or infant growth, but there are limited trials on any specific hormonal method. And really, obviously, future research is needed on progesterone-only contraceptives, including LARCs, and on the effects of initiation time on breastfeeding and infant health. We simply don't have studies that are sufficiently powered to give us very, very firm conclusions about this, although the preponderance of the evidence that we have so far does not really point to harm. I want to point out a couple more studies. This is actually the result of some research that was done at the University of New Mexico and also in Utah to give us a little bit larger numbers. This was also focused on immediate postpartum placement of the hormonal IUD. It was published in 2017 by Turok et al. This study, 132 women with immediate postpartum placement and 127 at 46 weeks. The time to lactogenesis in the immediate postpartum was not inferior. It was a non-inferiority study. And the results indicated that the time to lactogenesis was not inferior to cases when, or to the group that got their IUD in the office setting. And any breastfeeding at 8 weeks, well, that was 79% with immediate placement and 84% with delayed placement, which was not statistically significant. There is also another trial ongoing now that is focused on the implant. So we anticipate having the evidence base is continuing to grow, and people are trying to address this important sort of inadequacy and gap in our literature. I just wanted to point out, probably this is the most recent thing I could find that had been published last year. Levi et al. Did a secondary analysis from randomized controlled trials comparing IUD use at 6 months postpartum among women who underwent an intracesarean IUD placement with women who planned for interval placement at 6 weeks or more postpartum. And there were 63 cases in that secondary analysis. And the proportion analysis demonstrated no difference in the proportion of women breastfeeding at any of 3 time points that they looked at following placement, 6, 12, and 24 weeks. And this remained true after they adjusted for age parity and ethnicity. So that's the most recent study I could find. So That's the evidence for you to consider. And that evidence is distilled down into the medical eligibility criteria, which is a really important resource for contraceptive counseling around a variety of clinical conditions and uh, issues that can arise in complications related to pregnancy, birth, and postpartum. And these are the CDC recommendations currently specifically around immediate postpartum LARC and breastfeeding. The box is around the implants, the progesterone releasing IUD, and the copper IUD. And the legend, how to interpret the CDC criteria, green is good, right? So 1 means no restriction. This method could be used at any time. It's considered to be very safe. Number 2, which is advantages generally outweigh theoretical or proven risks. And this is common designation when our evidence base is underpowered or doesn't have a very strong, large randomized controlled trial basis to lead to a category 1 recommendation. And then on the negative side, a category 3 is where the risks generally outweigh the advantages, and 4 is really an unacceptable health risk. And as you can see, for implants and IUDs in breastfeeding, again, if you look at the subcondition, it will clarify the time frame. But in the immediate postpartum, which is defined here as less than 1 month postpartum for the implant. It's a category 2 for the implant. And for the postpartum placement for the immediate postpartum placement of the IUDs, also a category 2, which means that generally the advantages may, depending on a woman's individual circumstances, outweigh theoretical or proven risks. So this is the information that colleagues who are providing contraceptive services use to form the basis of their informed counseling with patients. But what if there are risks of breastfeeding difficulties? I'm sure this is occurring to a lot of you, many of you. What about a person's prior lactation history if they had abrupt decrease in milk supply after starting hormonal contraception? So this theoretical risk actually seemed to occur in their situation. Or if they had previous breastfeeding problems or a breastfed infant with slow weight gain, which is certainly what my personal experience was. And how about if there were perinatal complications, hemorrhage, hypertension, infection, all extreme physical challenges for a woman that can affect her ability to breastfeed, also if she is undergoing recovery from a major event. Or if she had a prolonged second stage, a cesarean, which is a major surgical procedure, and something that, where there's different recovery than from a vaginal delivery for sure. And infant considerations, if there's separation between a mother and a baby, if we have a low birth weight or a preterm infant, or if there's multiples. You're all familiar with these different breastfeeding challenges that many of us are really in place to help women address. And it's a really important question to think about how these concerns can be balanced. This is what the Academy of Breastfeeding Medicine has to say. And I think this is a powerful statement from their protocol number 13, which was released in 2015. They say every woman should be offered full information and support about contraception options so she can make an optimal decision for her individual situation. Physicians and other healthcare providers should not pre-decide which method is most appropriate. Rather, in discussion with the patient, clinicians should discuss the risks, benefits, availability, and affordability of all methods. And this discussion should address contraceptive efficacy and possible impact on breastfeeding outcomes within the context of each woman's desire to breastfeed, risk of breastfeeding difficulties, and risk of unplanned pregnancy. So really, what the American Academy of Breastfeeding Medicine says, given the evidence base that we're currently working with, is that we should be doing shared decision-making with our patients. I want to talk more about that, but I also want to let you know, before I go any further, I want to acknowledge that There is, as is said in the LARC Statement of Principles here, a complex history to the provision of LARC as a method that is really provider controlled, in the sense that a patient needs to engage the services of a provider to have the method inserted and also to have it removed. There are important ethical considerations that are really specific to LARC. I want to make sure you're all aware of this LARC Statement of Principles that was created by the Sister Song Women of Color Reproductive Justice Collaborative, based in Atlanta, Georgia. It was a really excellent organization leading very important work around reproductive freedom, and the National Women's Health Network. There are about 8 principles. This slide only has the first 2. The New Mexico Perinatal Collaborative is a signatory onto this statement, and we firmly believe that as much as we maybe should be thoughtful to not prevent women from accessing LARC methods because of our concerns around breastfeeding, we also certainly should not be targeting women for LARC methods, once again, based on our concerns, whether they be clinical or social, where a tremendous amount of bias can enter in, and really provide women with the information to make their own decisions about contraception and breastfeeding. Here is a graphic put out by Irvin, Blackberry, and Haynes that I thought really effectively makes an effective visual on regarding shared decision making. I think it's also important to point out that when I talk about shared decision making around contraception and breastfeeding, I want to acknowledge that the decision around which contraceptive method to choose is not exactly equivalent to deciding whether or not to breastfeed. I think there's a whole host of considerations, and again, focus of a lot of important work, and certainly another talk around shared decision making around breastfeeding. We do know that breastfeeding is optimal infant nutrition, and it is our role to provide women and families the information they need in a non-coercive way to make the best decisions about breastfeeding. But I am not talking about whether or not to breastfeed. I think that is different in terms of making contraceptive choices. Although what shared decision making will allow us to do when considering both of those together is really help a woman figure out where her priorities lie and what her experience has been. So really, it's where informed consent and person-centered care come together, as demonstrated in this graphic. Person-centered care takes into account the values, history, preferences, considerations, and experiences of the patient. And informed consent is where the clinician has responsibility for bringing in the evidence that is most related to the options she wants to explore. And in this way, a patient and provider make a collaborative decision that really helps a woman implement her goals. There's been some good research around shared decision-making that's specifically focused on contraceptive shared decision-making. Christine Dellendorf and the group at the University of San Francisco and the Bixby Center for Global Reproductive Health have published a lot about this, and there are references in my references slide. But some principles of contraceptive shared decision-making are that it really brings at least 2 experts together to the table for respectful dialogue. I say at least 2 because, of course, the patient might have other really critical resources in her life that are also experts on this family system, who also have an important voice. But at least 2 individuals, the patient with the expertise in their experiences and what matters most to them, and the provider who has a responsibility to be expert and up to date in the clinical evidence. It's a challenge in our current healthcare environment, where the time we have with patients gets shorter and shorter, and greater and greater and greater efficiency is being squeezed out of our work with patients, while our considerations and our knowledge, us knowing better, becomes more and more complex. So I just want to acknowledge that challenge. But I also think that with experience, really balancing relational and task-oriented communication does bring some efficiency into this process. And what I mean by that is, and this is something that Dellendorf et al. Have sort of identified and explored with women in studies, is that you can get to women's goals by establishing rapport and relationship, and that has to be based on sort of behaviors and questions that really indicate to a woman that her perspective is being sought and respected in clinical encounter. And then the task-oriented phase is women also want some efficiency in these encounters, and they want their questions addressed, and they do not necessarily need a lot of information about things that they have expressed no interest in. So that's something to keep in mind in terms of how to strike the balance. It's something that we practice. It's something that we need feedback from colleagues and our patients on, and constantly a journey to get better and better. But that is what we try to achieve in contraceptive shared decision-making. Research has shown that communicating with patients in this way and approaching decision-making in this way is associated with greater satisfaction with the counseling provided and with the method choice that patients make. I wanted to share a case with you all, and I don't think we have anyone actually on the call with us right now. So this is something that I anticipate folks may have the opportunity to listen to later. But I'll share the details of this case that was presented to me by Allison Stubing, who is a physician in North Carolina who is an expert clinician and in breastfeeding expert. And she presented this case that I think really came out of clinical practice of a 15-year-old, G2, second pregnancy, and who had just, who had a earlier termination and had just delivered a preterm baby at 26 weeks. In this scenario, the lactation consultant enters the room on the day of discharge as a resident physician at the academic medical center is consenting the patient for an implant placement. The lactation consultant asked the resident whether breastfeeding was discussed, and once prompted in this way, the resident advised the patient that there was, quote, possibility that the implant could have, in fact, her milk supply. If anyone who's listening to this later, I'm wondering if anyone can relate to a scenario like this, where really these conflicting, or not conflicting, but these different roles sort of bring different priorities to the scenario, and a number of questions emerge. And one thing, some questions that occurred to me, they're obviously not the only questions, maybe not even the most essential question, but some of the questions that occurred to me to discuss, and maybe you could consider or reflect on, are, what are the components of a case like this that are most compelling? What is your reaction as a clinician from whatever clinical perspective you bring to it, to this scenario? What strikes you first? And then, what additional information would you really need to adequately counsel this patient yourself? It's very bare bones. I didn't really present a lot of details. How would you counsel this patient? Are you concerned about her age? Is it the fact that she just gave birth to a 26-weeker who is obviously in the NICU, facing, significant concerns related to prematurity? And then what additional resources do you have available, or, would you need to help this young woman meet her goals? I think this could possibly be lead to a good discussion, but I'll leave it at that. I want you to know that there are good tools out there for contraceptive counseling. Bedsider.org is an excellent resource for contraceptive counseling, and Also, the U.S. medical eligibility criteria, which there also has a phone app and will have evidence such as the CDC graphic that I presented to you, really to put it at fingertips for anyone who is engaged with women. And and this also could be someone who's really sort of more working with them around breastfeeding, but to know sort of what the resources are available, what type of information they'll receive from another clinician, or help them figure out some of the questions they may have for their provider. Obviously, the best time to start these conversations, including conversations around breastfeeding intent and any prior or anticipated challenges, is really early in the prenatal period. We try to meet women, and we need to try to meet women wherever they're at, whenever we encounter them. But hopefully, all of us working together, some of these questions are being addressed, and some of the reflection and research that an individual woman or family needs to do can happen in the prenatal period. There are also statewide training resources that you should be aware of, hopefully are already aware of. We work closely with the LARC mentoring program based at the Adolescent Medicine Division, the Department of Pediatrics at UNM. This slide shows their website. They're often updating with training opportunities statewide that are focused on opportunities to get the most updated information and hands-on skill training related to the provision of LARC methods. And also our website, the New Mexico Perinatal Collaborative, is where you can find our immediate postpartum LARC toolkit, which has some specific clinical resources like graphics and PowerPoint presentations, but also clinical templates, and also the administrative guidance, billing guides to help hospitals and hospital-based providers provide this service to women. We are also available to do trainings, and we are certainly happy to try to either do a training much like this talk I'm presenting right now, or really tailor, update a conversation focused on breastfeeding if that's something that would be of use. And we also want to make sure for anyone who's able to see this soon that the next upcoming training opportunity is at the annual meeting of the New Mexico Perinatal Collaborative this year. We are co-hosting it with the March of Dimes. It will take place on Friday and Saturday, October 25th and 26th at the UNM Cancer Center. The registration link is on this slide. We all are invited, regardless of your role. If you work with or are concerned about women, families, and infants and community health in New Mexico, consider joining us. We will have a specific workshop focused on immediate postpartum LARC provision at that annual meeting. So I always like to end when I'm talking about contraception, regardless of the audience, with this question, and it's really just a question for self-reflection. It's one I have to ask myself. It's one I would like to recommend that all of us, consider, because we're all coming from different perspectives, and we might have different impulses around this. So, what is our primary role in providing contraception? Is it to really advance the important, certainly public health objective to reduce the pretty incredibly high rates of unintended pregnancy in our state and nation? Is it the critically important goal of assisting to increase the percentage of infants that are breastfed through 6 months or exclusively breastfed? Really, I would say that in the end, our goal above all of that is to trust women, to make the best decisions for themselves and their families. There are barriers to those decisions, which lead to the other concerns such as rates of unintended pregnancy and challenges around breastfeeding. When those barriers are encountered directly in the clinical space, we need to do everything that we can to remove them and make it possible for women to move ahead to achieve their goals. And when they are in a broader structural or societal space, we need to figure out who our partners are to work on these things. And I'd like to suggest that this is one of the places where the New Mexico Perinatal Collaborative can come in, working with providers and our policymakers to try to improve the conditions for breastfeeding for families across our state and improve access to contraception so that we are really better and better positioned to help women and families meet their objectives across these really important goals. Thank you for listening. I am completely open and would welcome any feedback and dialogue around this topic. I realize you might be viewing it later, but you can always reach me. This is my contact information on this slide. I'm very interested in critiques, questions, and opportunities to engage with any of you around how we can improve our outcomes around breastfeeding, contraception, and really our community health. So thank you so much for your attention.